Hey, my name's Stan, and in this video, I'm going to talk about radiobiology. This is part 2 of a lecture series introducing basic concepts. I would like to warn viewers that this presentation does contain images of people who have experienced radiation-induced skin effects. The focus of this presentation will be on skin effects specifically seen in interventional procedures. This will include the clinical use of radiation, the biological factors that influence skin reactions, the radiobiology of skin injuries, the initiating dose and time course of radiation injury, the interaction between different types of damage, the risk management of skin effects, staged and repeated procedures, and some grades of skin effect as defined by the National Cancer Institute. Please note, this talk is written based on the following review by Stephen Balter on fluoroscopically guided interventional procedures, a review of radiation effects on patients' skin and hair. To introduce the story, in the 90s, after a pause of over 50 years, reports of fluoroscopically induced skin injuries reappeared. These reports coincided with the introduction of fluoroscopically guided interventional procedures into the clinic. So we present this review by Balter et al. 2010 that revealed that literature around skin effects was at the time misguided. To address this issue, the authors share their consensus around understanding the radiation-induced skin injuries resulting from single interventional procedures. Now, it was known in the 90s that radiation-induced skin damage is a complication of radiation therapy. And you can see in this image on the right the first LINAC, or linear accelerator, at the Royal Brisbane and Women's Hospital from around 1956. Skin effects also became recognised as a rare complication of fluoroscopically guided interventional procedures, especially in cases where accumulated dose becomes significant after multiple procedures. The skin effects arising from interventional procedures can range from mild to very severe. Mild reactions can heal on their own and occur occasionally. These are acceptable considering the benefits of interventional procedures. But radiation reactions can sometimes be clinically devastating, with years of pain, multiple surgeries, and permanent disfiguration for the patient. Now, the management of skin effects is really important because it is our duty to take as many patients or cases that could be severe and try to drive them towards milder cases. So, this review by Balter highlights the importance of understanding properly these skin effects so that you can minimize the likelihood of severe events, anticipate outcomes when necessary, and make informed benefit to risk decisions around radiation injury. So it's important to monitor dose so that radiation dose can be managed conservatively. Dose data should also be used to effectively anticipate and manage the outcomes, and the radiation exposure data should be provided to follow-up specialists in some cases. The treatment of major radiation-induced injuries necessitates wound care specialists, dermatologists, plastic surgeons, among other healthcare professionals that will work in a multidisciplinary team. So it's really important to realize the severity and the impact that radiation damage can have on a patient's life. It's essential to provide follow-up where a patient has received a dose of radiation that has a fair chance of resulting in skin effects. So, physicians need to answer these questions. What skin effects can be expected from the dose the patient received? What general advice should be given to the patient? And finally, how should the patient be followed up? So, this is a gentle reminder that patients deserve for us to at the very least, care about their radiation dose. Fluoroscopically guided interventional procedures are performed using X-ray beams with energies ranging from 50 to 125 kVp X-ray tube peak voltage. Infiltrations range from the minimum permitted up to 1 millimeter of copper. This image shows the interventional suite. In the red circle is where the X-ray tube is located, and this produces X-rays that travel up through the patient. Good practice involves having the X-ray tube in this position so that backscattered radiation is directed towards the feet of the interventionalist rather than towards their upper body. In this red circle is where the detector is located, which captures the X-rays that have gone through the patient, allowing us to acquire an image. In older systems, these detectors were actually known as image intensifiers. In this red circle, you can see the display system, which is used to show real-time patient imaging, vitals, and other procedural data. And here, you can see the control panel, which is used to adjust imaging parameters such as X-ray tube peak voltage, angulation, and to switch between different imaging modes. Now, against the wall there, you can see sterile supplies such as catheters, guide wires, and so on, which are stored and ready to use whenever needed. Finally, in this red circle is the injector system, which is used to deliver contrast agents during angiography. So, the dose rates at the skin surface from these procedures range from less than 1 milligray per minute in the case of very low dose rate fluoro to around 1 gray per minute in the cases of DSA or cine-angiography in a large patient. So, single procedures have resulted in peak skin doses of the order of 10 gray. So, let's do some quick math. So, let's go through an illustrative example to gain a bit of intuition. So, let's say we have a DSA procedure, and given the dose rates are of the order of grays per minute, that we have a dose rate of 2 gray per minute. And since single procedures can result in peak skin doses of the order of 10 gray, let's say that a patient receives a skin dose of 20 gray. So dividing the dose by dose rate, we can get roughly the time that the beam was on. And in this case, the beam would have been on for about 10 minutes with the patient in its path. It is important to note that these procedures actually last for hours. But to conserve radiation dose and to avoid as much as possible skin effects in patients, the beam is only turned on when imaging is needed to guide the interventionalists. So, in the context of interventional radiology, the same region of a patient's skin may be irradiated again during a subsequent procedure, which could occur hours or years after the preceding one. The irradiation patterns differ from those associated with most therapeutic and accidental exposures. Radiation therapy with 250 kVp X-rays, which I'll call ortho-voltage X-ray beams, provide insight into the effects of radiation on skin. The physical dose distribution near the skin surface produced by these beams is similar to those in modern fluoroscopic beams. Ortho-voltage radiation therapy was, for the most part, replaced by therapy with higher energy X-ray beams by the late 70s. So the maximum dose delivered by beams in this megavolt range occurs at depths of millimeters to centimeters below the skin. This effect is also known as skin sparing. And this is the effect whereby dose buildup under the surface can minimize skin injuries. This is an image from 1960, and after years of work to develop the device into a clinical system, Varian delivered this first Clinac 6 model to the UCLA Medical Center. And this image from around 1970 shows that the addition of a linear accelerator made the University of Virginia one of the better equipped radiation therapy sections in the eastern United States. Because orthovoltage radiation therapy doesn't exhibit skin sparing, clinical radiation therapy with this equipment was prescribed in a way that minimized skin injury by allowing repair of sublethal radiation damage and some tissue regeneration between treatment sessions. And this idea is now commonly known as fractionation, which is now absolutely standard in radiation therapy. So since they operate at quite similar energies, the transfer of experience from orthovoltage radiation therapy to fluoroscopy is very relevant. Skin dose is influenced by X-ray field size, as backscatter from the patient increases with increasing field size. And for typical interventional fluoroscopic beams, the backscatter factor is in the range of 25 to 40%. The clinical concept that field size influences radiation response to the skin first came from a publication in the 1940s of tables of skin tolerance doses for different areas of human skin exposed to orthovoltage radiation. For a small field, the dose prescribed as tolerance resulted in moist desquamation because the small area did heal quickly, largely by means of cell migration from the field edges. The same reaction from the same dose to a larger field would not heal quickly and was thus clinically unacceptable. In subsequent studies in human skin, no influence of field size on the development of moist desquamation was found for fields 40 by 40 mils or larger. Comparable results have been obtained for pig skin, where for fields 22.5 mils in diameter or larger, field size had no influence on the development of moist desquamation. Now, since most interventional fields are larger than 40 by 40 mils at the patient's skin, the effect of field size can be ignored. Tissues at risk in these procedures include the skin, hair, subcutaneous fat, and muscle. The expression and severity of this injury varies and is dependent on several factors that affect the dose-response relationship and kinetics of healing. These include the total dose, fractionation, and in some cases, the size of the irradiated area. There are also many physical and patient-related factors that can affect the expression of injury, including smoking, nutritional status, compromised skin integrity, obesity, overlapping skin folds, the location of the irradiated skin, its coloration, and defects in DNA repair genes. So, the areas of the body have different radiosensitivities, and in decreasing order, you have the anterior aspect of the neck, flexor surfaces of extremities, and the trunk. And the radiosensitivity in different areas decreases, with the lowest radiosensitivity being the soles of the feet, palms of the hands, and scalp. The scalp is relatively resistant to the development of skin damage, but scalp hair epilation occurs at lower doses in comparison to hair elsewhere in the body. You can see on the right here in this figure radiation injury following a successful neurointerventional procedure for the treatment of acute stroke, where the fluoro time was about 70 minutes or 43 imaging series. Note, the head was not shaved, and focal epilation on the scalp and skin injury on the neck, but no skin injury on the scalp. No dose estimates were available for this case. There are other biological factors that influence skin reactions, such as pre-existing autoimmune and connective tissue disorders, which predispose patients to the development of severe radiation effects in an unpredictable fashion. And the cause is not known, but it has been suggested that concomitant administration of some medications may be a factor in sensitizing these patients. Listed below are a few drugs that are known to increase radiosensitivity, and others are also listed that, when given in conjunction with radiation therapy, can result in cutaneous toxicity. So it's important to have that in mind. An interesting phenomenon is known as radiation recall, which can occur minutes to days after drug exposure and weeks to years after radiation exposure. This is an inflammatory skin reaction of unknown origin that occurs in a previously irradiated body part after drug administration that can occur with chemotherapeutic agents, antibiotics, statins, and some herbal preparations. As discussed in the previous lecture, the response of normal tissues to the effects of radiotherapy depend on the radiation dose, fraction size, and the integrity of the tissue, which could be related to prior surgery, chemotherapy, or radiotherapy, among other factors. Now, interventional procedures are typically performed in one to a few sessions over a period ranging from days to months, and the number of sessions and their timing will depend on the underlying disease process and on procedural factors such as contrast material use. Below is shown an example where a patient had been stabbed, blood was leaking from the spleen at the site of the wound. Then, a coil was placed in the artery, leading to the damaged portion of the spleen to prevent further blood loss. Shown here in example 2 is a procedure known as radioembolization, which is typically performed in 2 stages about a week apart. The first stage involves pre-therapeutic imaging to visualize the blood vessels and blood flow and ensure that the following therapeutic stage happens as required without causing complications to the patient. So, in the below images, you can see that imaging of the yttrium-90 particles within the microspheres are adequately covering this lesion in the liver. And following those examples, I want to emphasize that the interval between sessions is important because of cellular DNA repair and repopulation. The effects of radiation on tissue are mitigated by the repair of sublethal DNA damage of viable cells and the replacement of kill cells by means of repopulation. Repair processes are essentially complete within 1 day of exposure, whereas repopulation can take up to several months to complete. Experimental models can demonstrate these effects. In the pig, moist desquamation occurs 50% of the time after a single dose of 28 gray. If the irradiation is delivered in 2 equal fractions separated by 24 hours, it then takes 36 gray to achieve the same effect. Further extension of the time interval, up to 14 days, does not permit a larger total dose to be delivered for the same skin effect. Based on this, we can conclude that the repair of sublethal DNA damage is completed within 24 hours. The DNA repair kinetics for other clinical endpoints are similar. For the early response of moist desquamation, repopulation is not seen in the first 2 weeks because a certain level of cell depletion is required before repopulation by surviving cells is initiated. After skin doses of less than 15 gray, repopulation of depleted cells in the basal layer is essentially complete within 2 months. Repopulation does occur more slowly with higher doses because of the dose-related decrease in the number of surviving cells in the basal layer. So repopulation of depleted cells occurs over a much longer time period in dermal tissue. Damage may be expressed in the epidermis, dermis, and subcutaneous tissues. When this damage becomes evident depends on the radiation dose and biological factors. The characteristics and timing of the signs and symptoms of radiation injuries are influenced by anything that damages irradiated skin, which could be sunburn, abrasion, or even having a biopsy. Prompt reactions are those that occur less than 2 weeks after irradiation. The most frequently reported prompt reaction is the early erythematous reaction. This can occur a few hours up to 24 hours after a radiation dose of more than 2 gray. Once this reaction is resolved, there is no conclusive evidence to suggest that it has any influence on subsequent responses. Shown here in this figure, a patient had a PTCA of the right coronary artery 6 months before 2 other PTCAs, which were performed an hour apart in a branch of the left anterior descending coronary artery. The latter 2 procedures entailed nearly 1.5 hours of fluoroscopy with concomitant radiography. And here you can see necrosis eventually happened. Early reactions occur 2 to 8 weeks after exposure. These effects take place in the basal cells of the epidermis and the germinal region of the hair follicles, or stem cells. These are the more rapidly proliferating cells in the skin. Cell differentiation and cell loss continue at the normal rate, but radiation inhibits cell proliferation and new cell production. So, the timing of the responses depends on the turnover time of the system and is independent of radiation dose. But the severity of radiation response in the epidermis and hair is dose dependent, since the reproductive survival of stem cells is dose related. A decline in the basal cell density to about 50% appears to provide a stimulus to the remaining viable clonogenic stem cells in the basal layer to proliferate rapidly. The number of such cells will depend on the radiation dose. These proliferating cells form colonies of viable cells within the otherwise degenerating epidermis. The number of developing colonies dictates the subsequent outcome. If large numbers of colonies develop, in the case of lower doses, they will coalesce. The erythematous reaction will resolve. The epidermis may display hyperplasia prior to full recovery, and this is evident clinically as dry desquamation. If a limited number of colonies develop, in the case of high doses, the areas between them will continue to lose cells from the basal layer at the same rate. All cells and viable cell layers will be lost from the areas between colonies at a time associated with the normal turnover time of the epidermis, which is typically 4 to 6 weeks. This represents the development of moist desquamation. Now, you can see in this image that was taken prior to this one that regeneration happens both on the edges of the irradiated area and from surviving cells that were partially shielded by the lead cross wires. This here is early erythema and developing moist desquamation. And this patient had received a high dose of radiation to the lateral aspect of the hip during radiographic localization of a brachytherapy applicator. Midterm reactions occur 6 to 52 weeks after irradiation. These are associated with the development of delayed lesions in the walls of blood vessels, in the dermis and subcutaneous fat. Skin with a dusky or mauve appearance provides evidence for the presence of ischemia, with a measurable reduction in blood flow and a reduction in vascular density 12 weeks after irradiation. The probability of developing either dusky mauve erythema or dermal necrosis depends on radiation dose. Shown here are slices through a region of pig skin obtained 16 weeks after irradiation with a single dose of 20.7 gray with orthovoltage X-rays. Now, you can see here partial thickness necrosis of the dermis and evident vascular changes that are present in underlying subcutaneous fatty layer. And here is a region of necrosis in the subcutaneous fatty layer. Primary long-term reactions occur more than 40 weeks after irradiation and include the further development of dermal thinning. Serial measurements of relative dermal thickness after irradiation show that this phase of dermal thinning develops between 52 and 78 weeks after irradiation. For single doses in the 10 to 33 gray range, this timing is independent of the radiation dose, but the severity of the reaction is dose-related. Radiation-induced telangiectasia is a well-recognized long-term reaction of human skin, representing the dilation of capillaries in the superficial papillary dermis. These vessels are often visible through the epidermis. They're rarely seen before 52 weeks after the completion of radiation therapy, but they then increase in both incidence and severity for at least 10 years. It has been suggested that the development of telangiectasia is secondary to smooth muscle degeneration in end arterioles in the dermis. If surgical intervention is required to repair acute ulceration, secondary ulceration or dermal necrosis, then the total thickness of irradiated skin and some subcutaneous tissue are usually involved. Provided that good healing is achieved, no subsequent radiation-induced reactions would be expected to occur. If these lesions are small and involved only a small portion of the exposed site, unassisted healing will result in the formation of extensive scar tissue. The healed wound will not have the strength of non-irradiated skin, and the atrophic dermal tissue will be at greater risk for subsequent breakdown. This provided table is from the British Columbia Cancer Agency and contains general advice for clinicians as to the required follow-up and information to be provided to patients. The effects listed may occur at lower doses for radiosensitive patients or at a higher dose for radiation-resistant patients. So, for example, the table says that for skin doses in the range of 0 to 2 gray, there is no need to inform the patient because there shouldn't be any visible effects. If the patient reports skin changes, then you should treat in response to the signs and symptoms. It is really important not to forget to consider this note at the bottom of the table that is usually accompanying such tables that you can find in the literature. Now, this says that these skin dose ranges and advice are applicable to the normal range of patient radiosensitivities in the absence of mitigating or aggravating physical or clinical factors. So, it is important to consider this. As we've seen before, interventional procedures are often divided into multiple sessions. And if there's no overlap of the entrance beam ports from the different exposures, then each session can be considered separately. But a conservative approach to multiple exposures of the same portion of the patient's skin is to assume that there is no repair of sublethal DNA damage when the sessions are performed on the same or successive days. The applicable dose is therefore the total accumulated dose delivered to the area of skin at risk. The effect of a second procedure within a few months is a function of the kinetics of skin repopulation after the initial procedure. A higher dose from the first irradiation slows repair because of a lower availability of stem cells. If the second stage is likely to irradiate exposed skin, the time between stages should be increased with increasing dose from the first procedure. In such situations, it is advisable to examine the patient's skin for radiation effects before starting a subsequent procedure. Interventional procedures can be repeated or new ones required after an interval of months to years. And unless the skin dose from the planned procedure is minimal or to a different skin field, it's not safe to assume that previous radiation doses can be ignored. Previously irradiated skin often looks normal, but reacts abnormally when exposed to another insult. If overlap is anticipated, skin doses above 3 to 5 gray from previous procedures should be included when estimating the expected tissue reaction from the additional procedure. Studies of moist desquamation recovery and the associated erythematous reactions have been performed in pigs. Split-dose studies with variable gaps between exposures have shown that full repopulation of the epidermis is complete when there is an interval of approximately 7 weeks between exposures of about 20 gray. For the midterm reaction, ischemic dermal necrosis, the recovery repopulation phase is much slower. There's no suggestion of any recovery until after at least 28 days. We should have it etched in our minds that after a radiation dose estimated to be higher than 10 gray, cutaneous tissue will never return to its pristine state. I'm now going to walk through some of the different grades of skin toxicity as defined by the National Cancer Institute. This patient had 2 fluoroscopically guided procedures that were performed through overlapping skin ports in a 65-year-old man. Now you can note the enhanced reaction in the overlap zone. The first procedure was performed 6 weeks before, and the second procedure 2 weeks before this photograph was obtained. Shown here is a grade 2 skin toxicity, where in image A, subacute radiation dermatitis from fluoroscopy during coronary artery stent placement. This photograph was obtained 2 months after fluoroscopy. Now, in image B, you can see that the lesion has progressed to hyperpigmentation, sclerosis, and ulceration 5 months after fluoroscopy. Shown here is another grade 2 skin toxicity, rare. There was radiation injury in a 50-year-old man. Photograph A was obtained 2 months after treatment, where there was approximately a 10 gray peak skin dose. And image B is the same patient 6 months after treatment, so we can see that the reaction has resolved. Shown here is a grade 3 skin toxicity in a pig. And you can see moist desquamation where dry serum exudates on the final day of a radiation schedule that involved 18 dose fractions delivered over 39 days, delivering a total dose of 72 gray. This reaction developed in the final week of irradiation. And note that the image was obtained in around 1960 and has been cleaned and enhanced for the review publication. Shown here is a grade 3 skin toxicity, where the increased severity of the reaction in the area of field overlap is evident. Now, shown here is a grade 4 skin toxicity, where ulceration happened 4 months after an electrophysiology ablative procedure in which the patient's arm had accidentally been positioned within the radiation field during a 10-hour procedure. The estimated peak skin dose was 15 to 20 gray. After plastic surgery, however, the patient's ulceration healed and his pain resolved. In this image, we have a final example of a grade 4 skin toxicity showing deep necrosis at the elbow months after procedure. Unfortunately for this patient, under the cover of sterile drapes, they had unknowingly rested their arm over the port of the X-ray tube during an electrophysiology and ablation procedure. Now, you may notice that these 2 worst images that I've shown were entirely avoidable. As a closing remark, I think it should be etched in our minds that we cannot predict skin effects in a specific patient with high accuracy. Thank you for listening. If you have any questions, please get in touch. And a final reminder that this lecture is entirely based on the review by Stephen Balter and others on fluoroscopically guided interventional procedures, a review of radiation effects on patients' skin and hair. Thank you.